All right, we'll go ahead and get started. Welcome, everybody. Thank you so much for joining the webinar today to listen to some great research projects. This is day 3 of our webinars, and so just remember to stay till the end, and I will notify you about CE information. This webinar will be recorded, so just keep that in mind. It will be published to the YouTube channel upon the ending of the CE period. So I'm your host today or webinar moderator. My name is Kelsey Zakauskas, and I am a solid organ transplant pharmacist at the University of Utah Health. And the objectives for the webinar today is to compare and contrast current center practices with the information presenting during the PGY2 research webinar. We will also summarize the results presented during the webinar and assess opportunities for improvement or change at your institutions based upon the information presented during the webinar. One important thing to note for people that are continuing to do research is the joint AST and ACCP research community has created a research tool that is available to members in the AST COP Hub and on the ACCP Transplant PRN websites. Check it out for helpful tips on regulatory information, data management, and survey-based research. If you have any questions, you can reach out to Dana Pierce as well. And if you scan the QR code on this slide, this will take you to the research toolkit. Our first section today on research projects is going to be on liver transplant, and I will turn it over to our first speaker.
Hi, everybody. Thank you for listening in. So my name is Lauren. I'm a PGY2 solid organ transplant resident at UCLA, and my research project is on the evaluation of terlipressin in hepatorenal syndrome. Next slide, please. And my abbreviations listed here. Next slide. I also want to preface this presentation by saying that we are part of a multi-center study on the use of terlipressin, but those final results are still pending. To give a little bit of background of hepatorenal syndrome, it is a severe impairment and manifestation of cirrhosis of the kidney function due to disturbances secondary to portal hypertension. There's two types where type 1 is AKI-HRS and type 2 CKD-HRS is often fatal with limited survival of patients from weeks to months. And it's also associated with higher inpatient mortality, longer lengths of stay, and higher costs of hospitalization. Next slide, please. So in the management of HRS, vasopressors are considered first-line therapy, with terlipressin being the agent of choice by the 2021 AASLD and 2024 AGA clinical practice update. However, there are several limitations of terlipressin. One of them is being the cost for the maximum treatment being a little under $100,000 just on the cost of the drug alone. It also can make patients ineligible for liver transplant due to ischemic events and severe respiratory failure, which is why more studies need to be conducted to optimize its use, especially in liver transplant centers. Next slide, please. So a bit about terlipressin. It is a synthetic vasopressin analog that causes vasoconstrictor activity in the splanchnic and the systemic vasculature. It was recently approved by the FDA in September of 2021. However, there is limited data on its use in the United States, which calls for more multi-center studies to be done, but it has been used in Europe and is part of their clinical guidelines for over 30 years now. Next slide, please. So I wanted to go over the CONFIRM trial, which was done in 2021. This was a phase 3 randomized double-blind placebo-controlled trial in the United States and in Canada. They used terlipressin acetate dosing, which is 1 milligrams equal to 0.85 milligrams of the base. And so they used 1 milligram IV every 6 hours and then increased to 2 milligrams on day 4 if the serum creatinine had decreased from less than 30% from baseline. They included patients who had HRS1 with cirrhosis, ascites, and rapidly progressive kidney failure with serum creatinine more than 2.25 within 14 days of randomization. And they included 199 patients in the terlipressin group and 101 patients in the placebo group. And so in the study, they found that the reversal of HRS was significantly more in the terlipressin group than the patients in the placebo group. They also found that more patients in the terlipressin group had HRS reversal without any renal replacement therapy. And also these patients did not have any recurrence by day 30, more so in the terlipressin than the placebo group. More patients in the terlipressin group did experience some side effects, with 14% of them experiencing respiratory failure versus 3% in the placebo group. Next slide, please. So for this presentation, I want to include the single center retrospective observational study results. We do have preliminary multi-center results that I'll be sharing here as well. But we included adult patients who had a diagnosis of cirrhosis with HRS1, and our timeline for the terlipressin dose had to be September 2022 and July 2024. And we will be using descriptive analysis for this presentation. Next slide, please. So our primary objective was looking at the efficacy of terlipressin in reversing HRS, and our secondary objectives looked at the safety and efficacy of terlipressin up to 90 days. And also for the multi-center study, we aim to consolidate into institutional logistics and using terlipressin as well. Next slide, please. So here are all of the data points that we collected. For HRS reversal, it was defined as 2 consecutive serum creatinine measurements that were less than or equal to 1.5, or patients had to have serum creatinine within 0.3 of baseline within 14 days of terlipressin initiation. And then patients also had to not be on renal replacement therapy for 10 additional days. The first 6 points and the secondary objectives are 90-day outcomes, and then the rest of the outcomes there are going to be part of the institutional logistical data points that we wanted to collect. Next slide, please. So this is the UCLA's criteria for use of terlipressin. I do want to note that both our hepatology and nephrology teams have to be consulted for a patient to start terlipressin. Patients also have to not use any concurrent nephrotoxic drugs or have any structural kidney injury, and also have a full infectious workup here as well. Next slide, please. So for the multi-center study, we have 28 sites included. For UCLA specifically, within that time frame, we had 12 patients that had at least 1 dose of terlipressin. 2 patients continued their care at an outside hospital and were transferred. And so in total, we have 10 patients included on our analysis. Next slide, please. Here are the baseline characteristics between our centers and also the confirmed trials. As you can see, it was pretty well balanced with a mean age of 54 to 64 years old. We have mostly female patients in our cohort, while the confirmed trial had mostly male, with alcohol use as being the most common cause of cirrhosis. And then our objective data was also pretty balanced between the 2 studies. Next slide, please. So in our cohort, we found that 3 out of 10 or 30% of our patients had reversal of HRS. Next slide, please. But if you compare it with the confirmed trial as well as the multi-center group, you can see that we all pretty much had the same rates of HRS reversal, which can speak to the validity of this multi-center study and the criteria that we have used. Next slide, please. Here, I also wanted to depict the trend of the serum creatinine up to day 14 from terlipressin initiation. As you can see, there is a steady downward trend with most of our patients. However, there are confounding variables, such as patients who were started on dialysis, etc. Next slide, please. We also have the 90-day patient outcomes. As you can see, we had 3 patients who had HRS reversal. Next slide, please. But we have 4 patients who had recurrence of HRS, though none of these patients were deemed to have HRS reversal. Next slide, please. And then 2 of these patients who had recurrence of HRS had to be started on renal replacement therapy. One of them stopped terlipressin early and was started on dialysis during their course. Next slide, please. We have one patient who received a liver transplant 28 days from initiation of terlipressin. And next slide, please. We had two patients who were readmitted. One was for paracentesis and ascites, and the other patient was readmitted for abdominal pain. Next slide, please. Here, I just wanted to depict the cost of terlipressin, with the first three patients being those who had HRS reversal. As you can see, the cost can rack up pretty high. For our institution, we spent a little less than $500,000 just on the drug cost alone. So this really highlights even more so the importance of optimizing terlipressin use. Next slide, please. And here's just a comparison of the patient outcomes. We have similar rates of patients who received renal replacement therapy in the confirmed trial and the multi-center group. I think other outcomes such as rehospitalization or death or TIPS procedure cannot be compared, since the confirmed trial did not report rehospitalization and TIPS procedure, and also our N is pretty small. Next slide, please. Here at UCLA, the most common adverse event we saw was bradycardia, in which therapy was held. And then in the confirmed trial, the most common side effect was diarrhea. Next slide, please. And so we believe that terlipressin effectively reversed HRS, as patients did not go back on renal replacement therapy or had recurrence of HRS. Although many of our patients did experience bradycardia, terlipressin was not discontinued and was just held. For our strength, this is a multi-center study with up to 28 sites involved, assessing real-world data outside of a clinical trial, and we aim to consolidate institution-specific criteria to better use terlipressin in these institutions. Limitations of this study is that it is a single center data that was represented today with a small sample size of 10 patients. It was a retrospective observational study design. Also in the multi-center study, there are varying local criteria for use as well. Next slide, please. So in conclusion, we found that our HRS reversal rates were similar to the confirmed trial, with bradycardia being the most common adverse event noted. For our institution, we use terlipressin second line to midodrine and octreotide. So I do believe that there are further studies warranted using this as a first line agent. Oh, next slide, please. Here are my acknowledgements. Next slide, please. And my references. And I believe we're doing questions at the end. Thank you for listening.
Thank you so much, Lauren, for that great presentation. Please use the question and answer function in Zoom for any questions, and we will hold those until the end, or put them in the chat and we will still hold those till the end. You can put Lauren's name and then your question, just so we know who the speaker's questions go to. And we will move on to our next speaker. Oh, you are muted, Abigail.
Can you hear me now?
Yes.
Okay, perfect. Sorry about that. My name is Abigail Hampton. I'm the current PGY2 solid organ transplant pharmacy resident at Rush, and today I'll be presenting my research project titled Cyclosporin Conversion Post-Orthotopic Liver Transplant. Next slide, please. To start off with this figure from the 2022 SRTR annual data report, this shows that majority of patients post liver transplant are maintained on a maintenance immunosuppression regimen that includes tacrolimus. Next slide, please. To provide some perspective on why tacrolimus is our preferred calcineurin inhibitor, there's this study done by Weisner and colleagues, which was with the objective to assess long-term safety and efficacy of tacrolimus and cyclosporin in primary liver transplant recipients, with a primary endpoint of incidence of biopsy-proven acute rejection. And what they found was that at 1 year, rates were significantly lower in the tacrolimus group compared to the cyclosporin group. So the key takeaway from this trial was that tacrolimus is safe and effective as long-term maintenance immunosuppressive agent in liver transplant recipients, and was associated with a lower rate of rejection. Next slide. Another notable finding from this trial was the rate of conversion between the different CNIs. So overall, 20.9% of patients in the tacrolimus group were converted to cyclosporin, with the most common reason for conversion being toxicities, whereas 13.2% of patients in the cyclosporin arm were converted to tacrolimus, with the most common reason being rejection in this case. And this study by Emre and colleagues looked a little bit closer into this, and it was a single center analysis of liver transplant recipients that were converted to cyclosporin for tacrolimus toxicity. So out of their 388 patients, 18% underwent conversion to cyclosporin, again with toxicity, specifically neurotoxicity being the most common indication for conversion, and noting that higher rates were seen in the early post-transplant period. They did also assess incidence of rejection post-conversion, which was 30%. Next slide. And there are a few different symptoms that can fall under this umbrella of tacrolimus neurotoxicity that I'd like to mention. So it could be headache, seizure, tremor, or altered mentation. And some of these are more gray area than others in terms of when should patients really be converted to alternative therapy, specifically altered mentation. So it's been seen at our institution where providers are really developing this lower threshold to transition patients to cyclosporin for this altered mentation, where there are a lot of other confounding factors that could be at play, such as residual encephalopathy and ICU delirium. So that serves as the purpose for this research. Next study, please. And just before I dive deeper, this is our current RUSH protocol for maintenance immunosuppression post-liver transplant. So we do initiate all patients on a tacrolimus-based regimen, but we do have some specific considerations for cyclosporin, which are at the bottom of the slide. So any patient unable to tolerate tacrolimus due to unresolving altered mental status, seizures, etc. Next slide, please. So the purpose of this study was to assess the impact of switching from tacrolimus to cyclosporin on patient outcomes post-LLT, with the hypothesis being that those recipients that are converted within 3 months of transplant are at increased risk of acute rejection at 1 year. Next slide. This was a single center retrospective 2 cohort study from the time period of July 1st, 2018 to December 1st, 2023. Next slide. Adult patients were included who received a primary liver allograft here at RUMC from that time period I just mentioned, and again that were converted from tacrolimus to cyclosporin less than or equal to 3 months post-transplant. Some key exclusion criteria include patients with a maintenance immunosuppression regimen at discharge that did not include a CNI, or patients converted to any maintenance regimen without a CNI or using low-dose CNI in combination with an mTOR inhibitor at any time within 1 year post-transplant, as well as multi-organ transplant and second or subsequent liver transplant. Next slide. The primary outcome was a composite of biopsy-proven acute rejection and preemptively treated acute rejection, where secondary outcomes were focused on patient and graft survival, as well as incidence of some opportunistic infections. Next slide, please. Overall, 193 patients were screened, 66 of which were excluded, most commonly due to patients that were converted to an mTOR-based regimen. In the end, 127 patients were included. 105 of them were maintained on tacrolimus, where 22 of them did undergo conversion to cyclosporin. Next slide. Here are the baseline characteristics between groups. They are pretty similar. Median age, roughly 54 to 59, mostly Caucasian. And I will note that for the biliary complications, it does look like there is a trend towards a statistical significance, but I will note that many of the patients in the cyclosporin group that did have these complications had them prior to conversion, so they were not on cyclosporin yet. And then also of note, during this time period, the induction agent did change. There was initially a lower methylprednisolone taper that was used historically, and that was changed to a higher version, but rates were similar between groups. And primary indication for transplant was alcohol. Next slide, please. And looking at the patients that were converted to cyclosporin, roughly 17% were converted with a median time to conversion of 16 days post-transplant and a median tacrolimus trough at conversion of 6.1. And this figure on the right shows the reasons for conversion. So that dark green box there represents altered mental status, which was the majority of why patients were converted, with tremors in the light green box being the second most common cause of conversion. Next slide. I will note that a good amount of patients were actually converted back to tacrolimus. So 10 of the 22, or 45%, were converted back to TAC with a median time to conversion back to tacrolimus of 33 days. And again, this figure is depicting the reasons why the majority of patients were converted back to tacrolimus due to rejection episodes. Next slide, please. This is a time to event analysis for the primary outcome. So this graph is depicting time to first rejection with time post-transplant in days on the x-axis and for proportion of rejection-free survival on the y. Tacrolimus is represented by that darker green line at the top there. So as you can see, as the patients progress towards 1 year post-transplant, there becomes a really apparent difference between the two groups, with rejection-free survival in the tacrolimus group being above 70%, whereas in the cyclosporin group, it's below 40%. Next slide, please. And to look at this outcome a little bit more closely, so overall, for the primary composite outcome was seen in 28% of the patients in the tacrolimus group versus 63% in the cyclosporin group. And most of the cases were biopsy-proven acute rejection. Median time to rejection was 16 days in the tacrolimus group versus 63 in the cyclosporin group. And the severity of rejection were pretty similar between groups. Next slide, please. And this is just a description of their immunosuppression at the time of rejection. So firstly, with the cyclosporin group, which was 14 patients, the median trough was 131, and a lot of patients did have their mycophenolate held and were not on any prednisone. So actually 6 out of 14 of them were on cyclosporin monotherapy at the time of rejection. Whereas looking at the tacrolimus group, which was 29 patients, their median trough was 6.1. There were still a handful of patients where mycophenolate was held, but in this case, only 7 out of 29 were on tacrolimus monotherapy. Next slide, please. And some of the additional outcomes that were assessed, so patient and graft survival were not different between groups. Neither was rate of CMV viremia. The rate of systemic fungal infections, they also appear different at first, but kind of the same scenario as earlier. 2 of the 6 patients in the cyclosporin group did develop these fungal infections prior to conversion. So that's just something to note. Next slide, please. So overall, with the discussion of this research, there are some limitations in the fact that it's a retrospective cohort study with relatively small sample sizes, as well as that the response to conversion was not assessed. And finally, as I've been mentioning throughout, the group assignment was based on initial conversion and did not factor in cyclosporin duration. There was a case in which at least one patient was only on cyclosporin for a few days, but all of their outcomes, anything that occurred, will be in the cyclosporin group based on the fact that they were converted. So that is just something to keep in mind. Next slide, please. But overall, the key takeaways from this research is that higher rates of rejection were seen in liver transplant recipients that were converted to cyclosporin compared to those who remained on tacrolimus. And these findings really highlight the need for assessment of these liver transplant recipients post-conversion for a possible reintroduction of tacrolimus, dependent on what their conversion indication was. So for specifically altered mental status. And then attempting to address all the underlying causes of altered mentation prior to conversion, as well as, since tremor was the second most common reason for conversion, also considering the utilization of Envarsus as an alternative option when tremor is the primary indication for conversion. Next slide. These are my acknowledgements. Next slide. My references. Next slide. And then any questions that you have, please put them in the chat. Thank you.
Thank you so much, Abigail, for that great presentation. Again, use the question and answer function if you have any questions, or use the chat and we will hold those until the end. And with that, we'll move on to our next section of presentations. These will all be in heart transplant, and we will move on to our next speaker.
All right. Hi, my name is Alyssa Stutz. I'm the PGY2 at Ochsner Medical Center in New Orleans. And today we're going to talk about my research in the intensity of statin therapy and its effects on heart transplant vasculopathy. Next slide. I'd like to thank my research team. Next slide. So overall, we're going to work on understanding the role of statin therapy as part of the post-heart transplant medication regimen, and then analyze the effect of statin strength on heart transplant vasculopathy in general. Next slide. Heart transplant overall is an established treatment for our patients with end-stage heart failure. We know that it's more effective than medication alone, whereas 90% of our patients are alive at 1 year post-heart transplant, whereas 50% of these patients are alive at 1 year on medication alone. Cardiac allograft vasculopathy is a form of chronic rejection, and it's a distinct atherosclerosis of the heart vasculature of the transplanted heart. Compared to native coronary artery disease, it is more of a circumferential, diffuse, and rapidly developing issue that causes chronic graft dysfunction. And it affects about 30 to 50% of our heart transplant patients at 5 years post-transplant. Statins have been shown to attenuate the development of cardiac allograft vasculopathy and improve survival. However, the exact mechanism of this is not known. Currently, the theories are decreasing inflammation in the heart that's transplanted, improved endothelial function in that heart, or stabilizing current atherosclerotic plaques that the patient has. What hasn't been studied is the relationship between statin intensity and the cardiac allograft vasculopathy benefit that we might see. Next slide. So for some literature, our landmark study is by Kobashigawa and colleagues, looking at their specific population in Los Angeles. They compared pravastatin 20 milligrams to a control of no statin therapy, and overall they found less cardiac allograft vasculopathy in the pravastatin group. When they did a follow-up 10 years later, they still saw less cardiac allograft vasculopathy and less death, and then they also saw increased survival at that 10-year mark. Recently, Elmatil and colleagues looked at their population in Nashville, and they compared a moderate to high intensity statin regimen to a low intensity statin regimen. And overall, they saw no difference in cardiac allograft vasculopathy-free survival between the two groups. More recently, Huang and colleagues in New York compared atorvastatin 20 milligrams to pravastatin 20 milligrams, and they also saw no difference in between groups. Next slide. So our study rationale is that there was limited data that existed for the efficacy and safety of higher intensity statins in the heart transplant population. So we wanted to look and evaluate at the effect of moderate to high intensity statins on cardiac allograft vasculopathy in this specific population. So we hypothesized that the incidence of cardiac allograft vasculopathy would be lower in patients on a moderate to high intensity statin versus those who are on a low to moderate intensity statin. Next. It was a single center retrospective cohort study done here at Ochsner in New Orleans. We included all patients from January 2012 to June 2023. We excluded patients who were under the age of 18, not on a statin at discharge, patients who died or were lost to follow-up at 1 year post-transplant, or those who did not have evaluable IVUS data or angiography at 1 year to determine the primary outcome. Next. So outcomes were assessed at 1 year after transplant, and they were compared between our moderate high dose statin group to our low moderate dose statin group. And this is how we decided to separate out our groups. Our primary outcome was cardiac allograft vasculopathy based on our angiographic ISHLT data defined as greater than 1, or our intravascular ultrasound data that was looking at a intimal thickening of greater than or equal to 0.5 whenever compared to baseline. Our secondary outcomes were biopsy-proven acute rejection, treated rejection, liver dysfunction, myalgia, and rhabdomyolysis. Next. So our continuous variables were reported as mean plus or minus standard deviation or median and interquartile range, and differences were analyzed using the t-test or Mann-Whitney test. Our categorical variables were reported as frequencies and percentages, and differences were analyzed using the chi-squared test. Our p-values were true-tailed and considered significant if the alpha was less than 0.05. And we did do a power analysis, and we found that looking at older studies, approximately 62 patients were needed in each group to achieve an 80% power, assuming that our CAV incidence was 30% in our low moderate dose group and 10% in our moderate high dose group at 1 year. Next. So then when looking at our baseline characteristics, we did meet power with 81 patients in our moderate high dose group and 103 patients in our low moderate dose group. We did not see a difference in age, gender, race, or coronary artery disease between our groups. Next slide. Again, we did not see a difference in our patients who had a high CPRA with using thymoglobulin induction. We didn't see a difference in CMV mismatch. Where we did see a difference is that we did see a larger amount of statin escalation in our low moderate dose statin group. So around 30% of our patients did escalate their statins within that first year post-transplant. And we did have a larger number of evaluable intravascular ultrasound data in our moderate high dose group versus our low moderate dose group. Next. Overall, we did not see a difference in cardiac allograft vasculopathy between our two groups. However, we did see a significant difference in biopsy-proven acute rejection between our two groups, with higher amounts of biopsy-proven acute rejection and treated rejection in our low moderate dose group versus our moderate high dose group. We did see similar rates of liver dysfunction, myalgias, and rhabdomyolysis between the two groups. We did do a multivariable logistic analysis looking at controlling for thymoglobulin use, treated CMV, as well as high CPRA. And again, we saw that our moderate high dose group was not associated with less CAV whenever we controlled for those factors. Next. So overall, for limitations, we did not, like our exposure definition does not reflect continuous statin exposure. As I said, we did have 30% of our low moderate dose group that did escalate their statin. So that is kind of something that we did not take into account whenever we were looking at our data. We did have issues with post-transplant monitoring, specifically during the COVID years. We had to exclude a lot of patients because they were canceling a bunch of the mandatory tests at that time. So we didn't have as many patients as we expected since we excluded a lot of patients due to not having their full IVUS or angiographic data. We did not trend low density lipoprotein from baseline. However, data doesn't really show that there is a connection between LDL and CAV as far as the data is concerned currently. And we did have a large proportion of our IVUS data be in the moderate high dose group, which could skew our data since it is more sensitive. So the patients in the low moderate dose group might have CAV just at a lower degree, and they can't be actually seen on angiography, and maybe IVUS would have caught it. Next. So overall, the study suggests that CAV attenuation is due to statins as a class effect and not dictated by their dose. We did see that higher dose statins are safe and have an acceptable adverse event profile. However, larger prospective studies are needed to confirm these findings. Next. Thank you very much.
Thank you so much, Alyssa. Again, save questions for the end. Use the Q&A function or put questions in the chat, and we will get to those after all of our presentations. And with that, we'll move on to our next speaker.
Hi, everyone. Thank you so much for attending this session. My name is Elise Gertis. I'm the current PGY2 solid organ transplant pharmacy resident at the Mount Sinai Hospital in New York, and I'll be presenting my research findings on very similar topic, essentially the same topic. So comparison of statin intensity and the development of cardiac allograft vasculopathy in heart transplant recipients. Next slide, please. So cardiac allograft vasculopathy, also known as CAV, is a recognized long-term complication seen following heart transplant. It's considered a chronic fibroproliferative rejection of the transplanted heart and is unfortunately among the top 3 causes of death after the first transplant year. The prevalence of CAV does increase over time, with reported prevalence being close to 10% after the first year, upwards close to 30% after 5 years, and almost 50% after 10 years, which is significant. And CAV may manifest as graft dysfunction in the form of arrhythmias, acute or chronic heart failure, and in the worst can be seen as sudden cardiac death. Next slide, please. In terms of diagnosing, so coronary angiography is a gold standard for diagnosing CAV, but other methods of intravascular imaging using intravascular ultrasound or IVUS, or also optical coherence tomography or OCT, can also be used as diagnostic tools. It's recommended for coronary angiography and IVUS to be performed every 1 to 2 years, especially in the absence of renal impairment. But baseline IVUS in conjunction with coronary angiography could also be performed at 4 to 6 years following heart transplant to exclude any possible donor transmitted or derived coronary artery disease. Next slide, please. There are several pharmacologic agents that have been studied and employed to, try to prevent the progression of CAV, one of them being mTOR inhibitors. They prevent and slow the progression of CAV given their anti-proliferative properties. And statins also reduce CAV and overall improve long-term outcomes regardless of lipid levels. So as a result, they should be considered for all heart transplant recipients. In addition, we also use antiplatelet agents for the prevention of CAV. In our institution, we start all of our patients on low-dose aspirin. Next slide, please. So kind of going into our study and, kind of summing up what has been said already, there really isn't any consensus regarding statin dosing as it relates to the development of CAV. So our study aimed to evaluate whether statin intensity affects the development of CAV in heart transplant recipients at 1 year. Next slide, please. So this was an IRB-approved single-center retrospective cohort study looking at adult heart transplant recipients who were initiated on a statin at the time of transplant between January 2015 through December 31st of 2023, and data was collected from the time of transplant until 1 year post-transplant. Next slide, please. And as I mentioned, so this was conducted at the Mount Sinai Hospital, which is an academic medical center in New York City, and our transplant center does about 50 heart transplants a year. Next slide, please. We included adult patients 18 years of age and older who had a history of heart transplantation at the Mount Sinai Hospital and who survived to at least 1 year. And the patients to be included had to be on a statin for the majority of their first transplant year. We excluded any patients who were converted to belatacept, cyclosporin, or an mTOR inhibitor within their first year, patients who had primary graft failure, and patients who had a combined organ transplant. Next slide, please. Our primary outcome was the incidence of CAV at 1 year, and for CAV, we used the ISHLT diagnostic criteria, so grade 0 to grade 3. And for secondary outcomes, we looked at luminal narrowing using the intimal medial thickness at 1 year. We looked at lipid levels and LDL levels at 1 year, looked at left ventricular ejection fraction at 1 year to assess for graft function, and also any side effects or discontinuations in each of the statin groups. Next slide, please. For statistical analysis, to delineate between the different statin intensity groups, so we delineated patients from low, moderate, or high intensity based on ACC and AHA guidelines. For continuous variables, we use means with standard deviations for parametric variables or median and interquartile range for non-parametric variables, and using a one-way ANOVA test to compare the differences between the groups. And for category variables, we report as sum and percentages and used chi-square of Fisher's exact test as appropriate. And alpha level for significance was set at a 0.05. Next slide, please. 284 heart transplant recipients were screened or patients were transplanted between the study period. 137 patients were excluded, mainly due to loss of follow-up or no follow-up imaging at the 1 year, which didn't give us data to assess our primary endpoint, and some changes in therapies as well. So overall, this led to 147 patients being included in our analysis. Out of those patients, 68 patients were on a low intensity statin for the majority of their first year, 42 patients on a moderate intensity statin, and 37 on a high intensity statin. Next slide, please. Looking at our baseline characteristics, we're fairly balanced between the groups when looking at age, sex, ethnicity, BMI at the time of transplant. We did see some differences in patients who were transplanted for ischemic cardiomyopathy, so more patients were in the high intensity statin group were transplanted for this reason. And also we saw higher hemoglobin A1Cs pre-transplant in patients who are in the high intensity group. But otherwise, hepatitis C, HIV status, and total artificial heart and LVADs pre-transplant were fairly similar between groups. Next slide, please. And looking at induction, so actually our center up until recently did not use induction for immunosuppression prior to heart transplant, so the majority of patients did not have induction immunosuppression. Looking at differences between cross-match results, DSAs, PRAs, no differences between the groups. In addition to immunosuppression at 1 year, SAVI prophylaxis at 1 year, and rejection at 1 year. Next slide, please. Looking at our statin therapy, so our time to statin initiation was about 6 days all across the groups, which aligns with our protocol where we try to start our patients on a statin if feasible within the first 7 days. And most of the patients were on a statin for the majority of the first year, so about over 90% of the time in the first year. Looking at the statin intensity upon discharge, so the majority of our patients were discharged on a low intensity statin. Per our protocol, we discharge on a statin, but eventually switch them to a rosuvastatin. So at 1 year, we can see some changes in statin practices. So at 1 year, the majority of patients seem to be on pravastatin, and the differences were statistically significant. Next slide, please. Looking at the results for a primary outcome, so the incidence of CAV at 1 year, looking at the ISHLT criteria. So there were no statistically significant differences seen across the 3 groups. Next slide, please. Our first secondary outcome was looking at the intimal medial thickness at 1 year. Unfortunately, in a lot of cases, we did not have access to that information. It wasn't documented, but comparing between the 3 groups, there are no statistically significant differences of IMT at 1 year. Next slide, please. Now looking at our graph function, so left of ventricular ejection fraction 1 year, kind of nearing statistical significance with best function seen in the moderate intensity group, but it did not actually achieve statistical significance. Next slide, please. And finally, we're looking at lipid lowering at 1 year. So I placed the baseline values for reference, although I mentioned them previously. And we can see almost a statistically significant difference in the groups, with the biggest change from baseline to 1 year appeared to be in the moderate intensity group. Next slide, please. Looking at side effects and discontinuations, fortunately, it was sometimes not documented as to the reason why medication was held or stopped. But in our low intensity group, 5 patients had cessation or pause in therapy in the first year. For 2 patients, is due to elevated CPK. 1 patient had muscle pain. 2, unfortunately, we did not have any documentation. And 2 patients had changed their statin altogether due to elevated CPK. In the moderate intensity group, fortunately, reason was not documented, and some had dose changes because of elevated CPK, and 1 changed statin due to muscle pain. And finally, in our high intensity group, 1 patient had held or stopped their therapy, and it was due to muscle pain. Next slide, please. Now looking at our study strengths and limitations, so we had a large number of patients screened over a long period of time. And since it's a retrospective study, this reflected real-world practice. And we thought that our exclusion criteria is appropriate to reduce the influence of confounding variables, such as we excluded patients who were also starting an mTOR inhibitor. So we can purely see if like statins had influence on CAV. As for limitations, this was a single center retrospective study. Due to the retrospective nature of the study, the comparator groups were uneven in number. And over time, since this study started in 2015, there are some differences in protocols and practice changes. Like in 2019 is when we made our change to start all of our patients on Pravastatin, then Rosuvastatin, but before that, there really wasn't any guidance. See, there's reliance on provider documentation, so some things we weren't able to find because it was not documented in the patient's chart. Something we really want to assess as well was the intimal medial thickness and comparing it from baseline, but in a lot of cases, they actually did not report or they did not perform like a donor cath at the 4 to 6 week mark, so we did not have a baseline comparator value. And kind of alluding to that, the donor information was not always accessible, so we couldn't assess for risk factors as well. Next slide, please. So based on our findings, so we didn't see that there's a statistically significant correlation between statin intensity and the development of CAV at 1 year. Further investigation of donor characteristics would be warranted to assess if there's any influence on the development of early CAV. And analysis of data beyond the first year post-transplant would be important to evaluate for CAV progression and prevalence. But at our institution, I did notice that we did initially want to do a 5-year follow-up, but after the first year, they turned to non-invasive forms of imaging, such as doing like a dopamine stress echo or PET stress exams, and we did not have results for the primary outcome. Next slide, please. Yeah, that concludes my study. Thank you all for listening. I hope this was informative.
Thank you so much for your presentation. Again, hold questions till the end, use the Q&A function or the chat, and we will move on to our last presentation.
Hi, everyone. My name is Foon Huang, and I'm currently a PGY2 at Yale New Haven Hospital. So thank you for this opportunity to talk about my research on the impact of pharmacist integration into our heart transplant clinic. Next, please. So the rationale for this is that literature assessing the role of pharmacists in heart transplant clinic is really limited. Research done by Prom and colleagues found that having a pharmacist as part of the team led to a higher percentage of patients at gold blood pressure, higher percentage of patients on statin, and fewer hospital readmissions at 1-year follow-up. There are other evidence too that showed positive impact of pharmacist integration on patient care in kidney and liver transplant too. In addition, the ISHLT guideline also highlights the impact of pharmacists on patient education and medication adherence. So given previous research and the recent expansion of our outpatient heart transplant team to include pharmacy, we wanted to evaluate the impact of pharmacist integration. Next, please. So in 2021, our ambulatory care clinical pharmacist joined the heart transplant clinic team, where she helps provide comprehensive medication review, medication counseling, and also chronic disease management too. Next, please. So for my study, this was a single center retrospective analysis of adult heart transplant recipients. Data from 2019 through 2023 were reviewed with pre-pharmacist integration timeline starting from 2019 through 2020 and post-pharmacist integration from 2020 through 2023. There was a 1-year washout period in between the two timelines. Outcomes that we looked at were implementation of both statin and aspirin at 1-year follow-up. For secondary outcomes, we looked at lab follow-ups, changes in hemoglobin A1C, LDL, triglycerides from baseline, and also percentage of patients achieving hemoglobin A1C less than 7%, LDL less than 100, and triglycerides less than 150 at 1-year follow-up. Next slide, please. Okay, so within the study period, 158 transplantations met inclusion criteria. Of those, 24 patients were excluded, whether due to death prior to the 1-year follow-up or transfer of care. So that ended up with 134 patients included for analysis, with 78 in the pre-pharmacist integration group and 56 were in the post-pharmacist integration group. Next, please. So in terms of patient population, so most baseline characteristics such as age, gender, type of transplant, transplant status, length of stay, induction agent, whether the patients had diabetes prior to transplant, and also the BMI prior to transplant were similar between the two groups. But in the pre-pharmacist integration group, we had more patients of white race and more patients had ischemic heart disease that led to transplantation. Next, please. For primary outcome, composite outcome at 1-year follow-up, we found that the pharmacist integration is associated with a higher percentage of patients being on both statin and aspirin, and this was statistically significant. However, when looking at individual outcome of percentage of patients being on either statin or aspirin alone, other not statistically significant, there was a trend of higher percentage of patients being on either statin or aspirin at 1-year follow-up. Next slide, please. For secondary outcomes of percentage of labs obtained at 1-year follow-up, more patients had labs obtained at follow-up after pharmacist integration, although this was not statistically significant. A similar trend was also seen with percentage of patient with A1C less than 7%, LDL less than 100, and triglyceride less than 150 at 1-year follow-up. Next, please. So for those that completed the routine monitoring and had labs drawn, we also looked at changes in A1C, LDL, and triglycerides. We found that there were really no significant differences from baseline for both groups. Next, please. So the takeaways from this was that pharmacist integration was associated with increased rates of statin and aspirin use as a composite outcome, which may have an impact on mitigating risk for CAV. Also, there was a trend towards, although not statistically significant, there was a trend showed that increase in patients obtaining labs monitoring at 1-year follow-up. Next, please. So that concluded my presentation. Thank you for listening and staying until this last presentation. Happy to take any questions you have.
Thank you so much for your presentation. This will now conclude all of the presentations for today, and we will have our question and answer opportunity for all of our wonderful speakers today. So again, use the question and answer function or feel free to post questions in the chat and we will get those answered for you. All right. For our last speaker, there's a question. How did the pharmacist select which patients to see? Did they see all patients each clinic appointment, or did the team help determine best suited patients to make a larger impact on? And I think that was for you, Feng.
Sorry, I totally missed that
No,
part.
I'll read it again, no worries. How did the pharmacist select which patients to see? Did they see all patients each clinic appointment, or did the team help determine best suited patients to make a larger impact on?
So at our clinic, at the beginning after heart transplant, pharmacists will be present at the very first appointment when they come into clinic. And then pharmacist is also present at subsequent follow-up clinic on a monthly basis. And then again at 6 months and then 1 year follow-up. So pharmacists will try to see all patients if possible. And then it really depends on the patient needs too. So if certain patients would require more care from a pharmacist, then we would set up more appointments to see those patients without the provider.
Thank you. And then a question in the chat, and this is going to be for Alyssa and Elise. For those who studied the statin intensity, do you still target high dose even with finding unknown benefit?
I can go first. So our protocol is actually for moderate intensity statin for all of our patients, with titration being kind of based on hyperlipidemia. So basically all of our patients get atorvastatin 20. We changed that as a protocol in 2018. We haven't made a change to our current protocol yet, just because we're publishing the data, but we're just kind of like working through what that would look like as far as what is a preferred statin for our doctors.
So I guess similarly here, so at our institution, we start everyone as soon as possible on pravastatin 20, so like low intensity, and then on discharge we do rosuvastatin 20. At least that's the plan, but we kind of like what Alyssa was saying, like kind of titrating to lipid levels. So obviously, if they need to make changes accordingly, that's kind of how we do it, and also titrating based on like side effects. So if they can't tolerate it, we sometimes change agents, lower the dose. So I feel like we don't have like a like a set thing. It's really just based on like clinical response.
Thank you. Let me double check and make sure there's no other questions. One question just quickly I had for Abigail. Do you guys try to potentially switch patients to Envarsus first before going to cyclosporin, or does your institution usually go from tacrolimus to cyclosporin for the patients with neurotoxicities?
Yeah, that's a great question. I was kind of surprised to see that 5 of the patients that were converted were due to tremor. It is definitely something that we do keep in mind and do try to do, but sometimes there's insurance limitations or other things. But we still do currently have a patient that's actually on cyclosporin due to tremors right now. So it's just kind of also some surgeon preference in there a little bit too.
Okay, thank you. And then one last question. Let me make sure there's none for Lauren. Did you find a reason potentially in your cohort why patients experienced more hypotension than the multi-center study?
I don't know if it's like the bradycardia, do you mean?
Yes, sorry, the bradycardias, yes.
Oh, I'm not 100% sure why I did notice that it was substantially like in almost every patient that it had to be held. But their starting heart rate was also high. I don't really have an answer for you there. I can get back to you after looking at a
No
little bit
worries.
more. Yeah.
This
But they
was
did have a map of about 75 in our cohort before starting terlipressin.
okay. Thank you. All right, awesome. Well, thank you so much again to our wonderful speakers today, and thank you everybody for staying on. You watch out for an email from me by the end of the week on how to claim CE credit. And if you have any questions for our speakers or anybody, feel free to email me and I will be able to forward on the information. So thank you everybody again for coming and have a great rest of your day. Take care.
Thank you.
Thank you.